we've got 30 in the room already, and I think there will probably be a few more trickling in as we go, but maybe we can make a start, because I'm sure there's a lot of discussion to be had in the conversation. So I'm Richard Norman. I'm co-chair of the Special Interest Group along with Lisa Higgins, and it's my pleasure to chair this session today. Before I start, I'd like to acknowledge the land that we do meet on, the traditional lands of various groups across Australia. I'm dialing in from Whadjuk Noongar land here in Perth in Western Australia. A few housekeeping points. The webinar is being recorded today, and it will be put up on the HEAT Special Interest Group webpage and on the YouTube channel. All attendees are being placed on mute and cameras are turned off. The chat function is also turned off. So I request that all questions be submitted via the Q&A function. I spoke with Joanna and Kirsty before, and their presentation is going to be around about half an hour, so that there should be plenty of time for discussion at the end of the session. So today's presentation I've really been looking forward to, because I think that it's a type of resource that is really underdone in many parts of the world. I think in Australia it's something we've been crying out for in terms of standardized methods for collecting cost data. I find that when I run economic evaluations alongside trials, finding validated tools for measuring resource utilization is something that every time I kind of curse the fact that no one's done exactly what you're going to be presenting on today, Joanna and Kirsty. So I'm really glad that you were able to dial in, and I'm really pleased that hopefully this can start something in Australia where we can mimic the kind of work that you've done using Modrum. So to introduce our speakers today, Joanna Thorne is a Senior Research Fellow in Health Economics at the University of Bristol. Her research interests encompass methodological aspects of costing health and social care, as well as applied economic evaluations conducted alongside RCTs and other study designs. Dr. Kirsty Garfield is a Senior Research Fellow at Health Economics and Health Policy, also at Bristol, and is employed also at the Bristol Trial Centre. She's experienced of conducting applied economic evaluation alongside RCTs and has a keen interest in trial methodological research. So it's a real pleasure to have you both here. I'll hand over to you now, and I'm not sure how you're juggling the slides between the two of you, Joanna. So maybe if I just hand over to you, and you can tell us how you want to present.
Yeah, thanks very much, Richard, and thanks for the invitation to speak. We're very, very pleased to do so. So I think Kirsty is going to put up the slides, and then we're going to talk a bit each about different aspects.
Okay.
So thank you very much. So we're going to be talking about how we've developed Modrum. Modrum is a standardized generic modular resource use measure, and it's been quite a long time in the development. A little bit of background to resource use measurement. I'm sure everyone is familiar with working alongside trials. We typically develop bespoke questionnaires, often for each new trial. We might take an old one that we've done before, tweak it a little, and then use it for the new trial. But that's time consuming, and there's a lot of reinventing the wheel that goes on. It also leads to a lack of consistency in terms of the resources that are included or excluded, and that might be appropriate. It might be appropriate to want to include resources like dental appointments in a cleft care trial, for example, but it might not be so relevant for a heart failure trial. There's also a lack of consistency in terms of the level of detail that's requested. So in some trials, we'll be collecting very detailed information about every little piece of costing information, and in others a much higher level. Often we have insufficient time for piloting or validation because we're working to a deadline, often to get an ethics application in. And typically there's very opaque reporting of the methods that people have used to develop the resource use questionnaires that they use in trials. Next slide, please. So this is just the quote from Drummond's book. The skill in costing is to match the level of precision and the effort to the importance in quantitative terms of the cost item. And this is something we do try very hard to do. We put a lot of effort into the cost drivers, the things that are going to really affect the economic evaluation. And we try to not put so much effort into the less important, the very cheap items that are not going to make much difference. Next slide, please. So what do we think the benefits of standardisation are? Well, it can reduce burden on both the patient and the researcher. If we have a well-validated tool that we know patients understand and are going to be able to answer the questions that we're asking, it reduces the cognitive burden for them, and it reduces the researcher burden if we're getting data in a standardised format that we can analyse very easily. If we standardise, we can validate measures more. We have time to do that. We can go into quite some detail about how well the measures are working and how well they're doing the things that we want them to do. And it can also lead to better comparisons across trials if we're including at least a core set of items that are important, and opens up the possibility of meta-analysis. I haven't seen it done, but it does, at least if we've got a standardised set, then it may be possible to do some meta-analysis of economic evaluations in future. So I just wanted to acknowledge that there are some standardised resource use measures that have been developed by other people. One that we use a lot in the UK is the Client Service Receipt Inventory, the CSRI. That was developed in the mid-80s, I believe, in the context of mental health trials. And it was developed for interview completion. However, there are many different versions, probably more than 400 or 500 different versions of the CSRI, which are usually just described as a modified CSRI, and we don't really know what those modifications have been. The annotated patient cost questionnaire was developed by Sarah Wordsworth, I believe, as part of her PhD. And this was an attempt to draw together all the questions that you might want to ask. And it gives a suggested text and suggested preamble and the questions that you might want to use. And you can go through and pick out the ones that are relevant to your situation. It's about 70 pages, I believe, and it hasn't been well used, unfortunately. But I suspect that is because of the length. It is quite a tricky thing to set up in the first place. There's also the Caregiver Indirect and Informal Care Cost Assessment Questionnaire. So that's specifically for measuring informal care. There's the IMTA suite of resource use measures that were developed in the Netherlands. So although there are versions of their resource use measures in 6 languages, because it was developed in the Netherlands, it doesn't necessarily work very well in the UK because they've included things like a Caesar therapist, which wouldn't be understood widely in the UK. And there's also the Pecunia resource use measure. So Pecunia was a consortium, an EU-funded project with 10 partners across 6 different European countries. And the idea was to build a resource use measure that could be used in trials that were being conducted across Europe. It's very detailed, it's very comprehensive. It includes the healthcare and social care, but also education and criminal justice. And it's very complete and asks a lot of questions. And so those are the ones that exist already, and then Modrum is the one that we've developed that we're going to be talking about today. So we've taken a very different approach with Modrum. We wanted to minimise it. We wanted to have a very small questionnaire that still captured what we need to do an economic evaluation properly. Next slide, please. Thank you. So the preparatory work started, well, about 10 years ago now, and we wanted to work out what the core resource use items that should be included in every economic evaluation would be. And so we conducted a Delphi survey. Delphi is a consensus technique, so we ask experts to provide judgment on items. So we suggested to them, for example, GP visits, and then we asked them to provide judgment on how strongly they felt that GP visits should be included in a in an economic evaluation. So it's an iterative process with feedback. We have one round where we ask everybody to provide judgments, and then we feed it back to them along with the averages, the group average, and their own, remind them of their own scores, and then ask them to rescore. And the benefits of doing it this way are we maintain anonymity, so we don't have dominant voices that are dominating the conversation, and we can include people from a wide geographical area. But just to note that we were focusing on the UK, so it was within the UK. Next slide, please. Thank you. So the Delphi survey, we started by reviewing existing resource use instruments, those held in DIRAM. So DIRAM is the database of instruments for resource use measurement, and it's a repository of resource use measurements that people have submitted. There's nearly 100 now, so when this was done there were only 59. But we extracted over 2,000 items, which we then grouped and ended up with 60 NHS and personal social services items. So things like visits to healthcare professionals in the community and medications. We then recruited a Delphi panel, and that was health economists with experience of doing economic evaluations alongside clinical trials and based in the UK. And we've recruited them via our health economist study group mailing list and personal approaches to authors who had published health technology assessment articles fairly recently. And then we set the consensus criteria. So we would only keep an item in the second round if more than 50% of the participants rated it 7 to 9, i.e. they felt very strongly that it should be included, and fewer than 15% rated it 1 to 3. Next slide, thank you. And the results of that, we had 45 participants, 34 items passed into round 2, and then 42 came back to do round 2. All of the participants changed some of their scores, but there wasn't a consistency in direction. Some moved up, some moved down. And eventually 19 items met the criteria, either to be included in a resource use measure or not to be included. And then we held a final item selection meeting to discuss the ones that didn't meet consensus. And what we came out with at the end of that meeting were 10 items that had been agreed should be included in a brief resource use questionnaire for all, or at least most, clinical trials. And that covered hospital care, emergency care, all the standard things here. Next slide, please. And the conclusion from this was that it did seem to be possible to reach a consensus on which items were important to trialists generically in every economic evaluation. And that suggested that it wasn't a wild goose chase to try and develop a standardised instrument of core items. But we did note that there would probably need to be some flexibility in the use of the instrument. So I'll hand over to Kirsty now, who's going to talk about how we took that preparatory work and turned it into MODRAM.
So when we started to develop MODRAM, we came up with some design principles for what we would like it to look like. So first off, we wanted it to be standardised, so to increase the consistency and the comparability across trials. We wanted it to be generic, so we could use it in a wide range of trials alongside different healthcare conditions and settings. We designed it to be flexible, so we thought that there wouldn't be uptake if we were very strict about the rules about how people used it. So there's flexibility in terms of the recall period and in terms of sort of examples that you can give. So you can give specific examples to the condition that you're looking at. There's also flexibility in terms of we have a core brief module and then we have a depth module. So that allows you to collect more detailed information, say on cost drivers or highly utilised resources. We wanted it to be precise, so we want accurate cost estimates. So if you have something that's important to get accurate costs, very detailed costs, you could use the depth questions. But then we wanted to balance this with conciseness, both for the participant answering the questionnaire and also the analysts sort of reviewing the data. So the core module doesn't contain any free text, so it makes it quite nice to analyse and quick for a participant to answer. We wanted it to be comprehensible, so that's why we did a package of sort of interviews with patients to sort of make sure that people understood what the questionnaire said. And then finally, we wanted it to be transparent. So that's both in terms of how we developed the questionnaire. So we've published papers about the development so people know what happened. But we also want to be transparent in how people use the questionnaire. So making a questionnaire that people can report they've used it in their papers, and it's quite clear what people have collected and what people have done. Okay. This is just a history of MODRIM and the development from the beginning of the Delphi study in 2015. Then we moved on to the healthcare module, which I was just discussing. In 2021, we got some funding, separate funding to develop informal care, social care, and aids and adaptations modules. And then most recently, from about 2023, we've been developing an electronic version of MODRIM. So back when we started the development of the healthcare module, it was pre-COVID era, and most questionnaires would be answered on paper, but now it's flipped the other way. So we thought it important to develop an electronic version and conduct some testing along with that to make sure it works as expected. Here's just a little look at the core module. So it's 2 pages, the paper version. On the left-hand side, you'll see there's 5 questions, all related to sort of hospital care, secondary care. And then on the right-hand side is the primary and community care questions. So we ended up with 11 questions in total. You'll see the flexibility in the questionnaire in the square brackets. So at the top, you can say that it's sort of condition-specific resource use you want or generic resource use. You can change the recall periods, as mentioned, and examples. And this is just a brief look at how the core question differs from a depth question. So in the core question, we only want a numeric response. So just how many times have you had an outpatient appointment? When you look at the depth question, we're asking for some free text information. So we're asking about the type of clinic they went to, if it was an outpatient appointment, if they had any tests or surgical procedures, and what the reason for that appointment was. I think the good thing about MODRIM is that the table, you still have that sort of core top level question. So if people are given the depth question and they didn't fill out all of the table, you've still got some information for costing on the core top question. In the electronic version, we're also trying to sort of add in more functionality to reduce burden. For example, for clinic type, you could put in a drop-down list of sort of the common clinics that you might expect in your trial. The first thing we did in terms of testing is we went to some health economists and interviewed them over the telephone to get their first feedback on the first draft of the questionnaire. So it was 10 UK-based health economists, and they had had recent experience of a trial-based economic evaluation. And I was asking them to tell me about relevance, whether things were clear and concise, and if there was anything we'd missed from the questionnaire. And their feedback, first we got that there should be more detail for some items. So they wanted an option to add resources that might be pertinent to their trial. So for example, if a district nurse was really important, you could add that as a separate question before going on to other healthcare professionals. Some people said there should be less detail. So in the Delphi study, it said we should collect prescribed medication names. But when I spoke to health economists, they said this might stop people using the questionnaire if we'd force people to collect prescribed medications, because they're often not completed very well. You could get them from other things such as medical records. So it's flexibility. You can include it if you want to, but you don't have to. There was areas where they said we should collect alternative details. So, for example, collecting the number of prescriptions rather than the number of days people were taking a medication. So the cost is driven by how many prescriptions people collect. There were some formatting alterations, and then finally there was some advice around implementation. So people said they would like a user guide to instruct them how to adapt the questionnaire and what's permitted and what's not. I then went on to do some interviews with patients. These were Think Aloud interviews with retrospective probing. So the Think Aloud part of the interview was they answered the questionnaire while they verbalised their thought processes. So I didn't interrupt them while they were answering the questionnaire. And by verbalising their thought process, I could see if they were sort of struggling with a question and try and see if they were making any errors in the interpretation of the question. After that part of the interview, I went on to do some probing. That was to ask them follow-up questions. So if there was any areas where they'd struggled, I could ask about that, and also some areas of interest. So was the questionnaire acceptable in terms of the length of it? We used a purposeful sampling strategy with maximum variation to try and talk to people from different ages, sex, etc. And then the data analysis took two forms. So first off, we did some data scoring, and on the right-hand side, if they struggled, so that means they didn't get the wrong answer, they put the right answer, but they seemed to struggle with the question. And then the second part of the analysis was some qualitative analysis of the responses to pick out any themes. So from these interviews with the patients, so there was 20 interviews in total, and we found that 80% of the questions answered were answered without any error or struggle. 7 of the participants completed the core module only, and 13 completed the longer version of the questionnaire. So on the top here, we had 28 errors in comprehension, and these were scored by 6 participants. And the majority of the errors were scored by 1 participant who included their interactions of their child, so their healthcare from their child. So based on that, we just added a note to say it's about your healthcare only, not your family or your children. On the left-hand side, so we've got outpatient. I'm not 100% clear what that is. I just assumed by the example you'd given, that sort of defined it for me. But at the beginning, when we first drafted the questionnaires, we kept them as concise as possible. So how many times have you had an outpatient appointment? And then in round 1 of the interviews, it revealed that people don't really know what outpatient means. So we added some examples in, and then by round 3, people understood what it meant just by looking at the examples. It helped them to understand. And then the final quote is about acceptability. So this person, they hadn't used many resources around the time they answered the questionnaire, but they felt that if they'd answered the questionnaire near to when they'd had a significant procedure, it would have been quite onerous to complete the questionnaire. And that was the core module with all of the depth questions. So I think it's just a warning that only collect sort of depth questions for things you really need it for, especially if people have been sick and they're using a lot of resources, to minimise the burden on them. And then we went on to some piloting with health economists. So we went to some UK-based health economists who were working on a recently funded trial and asked them to adapt Modrum using the Modrum user guide and provide some feedback in a survey. So we had 11 people complete it, and then most of them used some of the depth questions. On average, people took about 2 hours to adapt the questionnaire, which I think is a lot shorter than I've spent developing questionnaires from scratch in the past. And there was 4 respondents that made some adaptations that weren't specified as permitted in the user guide. And I think that's the thing with sort of resource use measures. People, make adaptations and they're used to making those. So things like that can happen. The feedback was really positive. So people thought it was quite easy to adapt. They thought they'd be able to apply some unit costs quite easily. They felt the user guide was helpful and were confident that they'd probably use Modrum in the future. And finally, for the healthcare module, I went on to some piloting with patients. So we recruited people from the southwest of England via the post through their GP practices. They answered Modrum, either the core module or the core in depth. They gave us some sort of some characteristics, and then to make it more like a trial and to have information on sort of quality of life, we asked the EQ5D as well. We also asked for their medical records, their primary care medical records, so that we can compare the questionnaire data with the medical records. So in terms of acceptability, we had a 14% response rate, which it's hard to compare it to anything. It's not like a trial, it's a random letter in the post, but that's how many people responded, and they reported it took 5 to 6 minutes to complete. The item completion rate was 96 to 100% for the core module, so really high, and 91% and above for the depth module. We found some evidence of construct validity, so the relationships were as expected with the variables, and criterion validity. So there was agreement for GP consultations and prescribed medications, but we found that there was more resource use reported in Modrum for other healthcare professionals. And that's likely because for that question, we asked about sort of health clinics and things in the community, not just the GP practice, whereas the GP practices are just picking up consultations there. I'll hand back to Jo.
Thanks, Kirsty. So we've got the healthcare module developed now, but we also needed, in order to do a personal social services and NHS perspective in the UK, we also needed some social care modules. So we decided to develop social care, informal care and aids and adaptations modules. And the idea is that these would be used in conjunction with the healthcare module. The healthcare module would always be used, but then you could bolt on just the social care if that was important, or just the aids and adaptations, whatever is relevant really to your particular context. So we took a slightly different procedure to develop these modules, but drawing quite heavily on the experience of developing the healthcare module. We started by doing a review of both existing instruments and a literature review to identify items, and eventually we reduced that to 203 unique items. We also ran that by some social care professionals to see if we'd missed anything in particular. We then held some focus groups to prioritise the items, to choose the ones that we were going to include in the modules. And then we did some rounds of cognitive interviews, think aloud interviews with people who access social care, and some in-depth interviews with health economists to look at the acceptability and validity. And then we carried out a pilot test. Next slide, please. So in the focus group, we carried out one focus group with health economists, and we asked them to rank the items before the focus group discussion. And remember, we've got 203 items, so we broke it down into groups and tried to make it a little bit easier. But we didn't ask the public, members of the public, to do that ranking exercise. But the health economists came back with things about staffing and about looking for major cost drivers, as in the quote on the left, and then also thinking about equipment that might be really, really expensive, so more cost drivers. We then carried out an online focus group with 4 people who access social care. So they were either people who used it themselves or carers for somebody who used social care. And then they looked at whether it was sensible to include the things that the health economists had identified as important, but they highlighted things where they would have found it difficult to quantify it, or indeed to know who pays for it. It's quite complex in the UK, the way that social care is funded, and it's not always obvious who is paying for a particular service. Next slide, please. So after that process, these were the items that we identified as being relevant for inclusion in the 3 new modules. So in the informal care module, we wanted the relationship to the carer, the hours of care and whether they live together. And then we added some depth questions about occupation and caring activities in case people want to cost it differently. For the social care module, we included care assistant or home carer, a care planner, so somebody like a social worker or a care coordinator, day care, and then classes or groups that people might have gone to. And we split that into 3 columns for who might have paid for it. So it might have been paid for by the council or the local authority, it might have been charity, or you might have paid personally. And we felt that would collect, would remind people of things that they'd used, and we'd collect better data if we asked who had paid for it. And then we had some depth questions in more detail. And then the aids and adaptations module, we split it into 4 sections, so very cheap things, less than £10 in UK currency. 11 to 100, 101 to 1,000, then over £1,000. And again, we asked people about who had paid for it. Next slide, please. So we then carried out some cognitive think aloud interviews with members of the public who access social care. And this was to test face validity, content validity, wording, comprehensibility and acceptability, and it did throw up some issues with terminology that people don't necessarily understand. So home carer, is that someone like you would say a formal housekeeper or a family member? And also threw up that we were asking about different times. Sometimes we were asking about days and sometimes about weeks, and that was making it confusing for people. And we did some semi-structured interviews with health economists, and we actually did these in parallel, the think alouds and the qualitative interviews, so that we could make adjustments and test and make adjustments and test as we went along. And the health economists came back with things that they thought were good. So they liked the fact that it had got the 3 different cost payment vehicles, but the core informal module came across as being quite long and repetitive, but they felt that it was a necessary compromise. Next slide, please. We then carried out a pilot. We asked people to volunteer to receive a questionnaire. So we sent out 113 questionnaires and had 74 returned. It took people an average of 11 minutes, and that was to complete the healthcare and the social care questions. Most people found the modules fairly easy to complete, but there were some people who found each of the individual modules a little bit difficult for particular reasons. And we also had somebody who was glad that we were asking about this type of thing. But somebody pointed out that there wasn't a yes/no option, which we'd used for some of the other questions for social care, and queried whether there should be. So we were able to make changes on that basis.
So just to give you a bit of how Mudrum's being used in the UK. So it's now being used in over 30 studies in the UK. And on the right hand side are just some of the areas. So it's been used in a wide range of areas, from cardiology, shingles, hip replacement and physical activity. So it's a breadth of studies that are using Mudrum. And some of the studies I'm working on, I'm including additional validation work, which I think is sort of valuable going forwards to build up the base of evidence for validity. So one trial, the TIGEL trial, which is looking at eczema in children. I'm doing some cognitive interviews. So Mudrum is currently only validated for adults. So I've adapted it for children and doing some interviews with the parents to check it's valid for that. And there's a couple of trials where I'm doing some criterion validity checks by checking the data from the trial using Mudrum to data from medical records. So a bit about ongoing and future work. So at the moment, as I mentioned, we're developing eMudrum, an electric version of Mudrum, and doing some testing. The aim of developing this is to sort of maximise the use of online features to reduce the burden on participants. And that's been developed in REDCap, but we do plan to develop it in other systems as well, most commonly used in the UK. We'd like to expand Mudrum for international use. So we've had interest from people from countries outside of the UK to use Mudrum, but as you'll see, the sort of NHS focus makes it quite specific to the UK. So it would need some adaptation and some validation before it could be used. And then finally, we're also looking to develop some different versions, so for underserved populations, such as Easy Read and Proxy, and then some new modules. So we'd like to develop a productivity module, residential care, sort of condition-specific modules. So there's lots of things on the list that we'd like to do in the future with Mudrum. And I've just got some references here to the papers that we've published from Mudrum so far. A link if you'd like to go and look at a copy of Mudrum and where people can use it. Just to acknowledge our funding from the MRC and from the NIHR for these projects. And finally, just some acknowledgements of people we've worked in the team and our public advisory group and our participants. Thanks for listening. Yeah, we're open to questions.
Thanks so much, Kirsty. Thanks so much, Joanna. That was really fantastic and really terrific to hear the work you've been doing with Mudrum. It's a really, as I said at the start, it's an extremely valuable resource, and I think that I would be surprised if there weren't a similar kind of initiative happening here, you know, mimicking what the great work you've done over in the UK. We have a couple of questions in the Q&A, and I encourage other people to drop their question in there as well. The first question was from Carrie Ann, and she said that I imagine there'll need to be considerations about balancing the need for comprehensiveness and maintaining comparability versus respondent burden. What kind of guidance will be given for the choice and selection of depth questions?
I can take that. So I think it needs to be driven by the trial that you're working on, and it's the cost drivers in the trial and highly utilised resources. Ideally, you'd run the questionnaire through your sort of PAG group or your public advisory group before going forwards with it. And I think that the comparability will always remain, because we've got those core questions that will be in all of the questionnaires in all trials. So even if you're collecting more detail on something, there's comparability in the core module, which is nested within the depth.
And I think also to add, it's probably better to start with the core and only include the depth where you really need to. So in principle, keep it as short as you can and only include the extra information where you really do need it and have a good rationale.
Yeah, great, thank you. The question from Lydia Engel from Monash. Is there a reason why the recall period was not specified, and do you provide guidance in terms of which recall period is most suitable in various situations?
So I think it was pragmatism in terms of we wanted people to use the instrument, and if we specified that only 3 months was going to be appropriate, then it probably wouldn't be used in a trial in which the data were being collected at 4 months, for example, when the outcomes were being collected.
Yeah,
yes.
Thanks.
Just to add, sorry, in the testing we did use 3 months, and it seemed people could recall over that time period. But yeah, we're not setting guidance on what you should use, because it needs to be open.
Mm-hmm. Yeah, thank you. I had a question about proxy completion. I wondered if you'd done any work around using it where the information is being completed by carers or by parents or by people looking after people who can't reasonably complete it themselves. Has it been tested in that setting as well?
So we haven't done a proxy complete version yet. We'd like to do a package of work to develop that. The only time I've used it in proxy is in the Tiger trial, which I mentioned, which is parents of children aged under 2. So I adapted it for that. And I found it really interesting that the parents were less familiar with sort of jargon and sort of medical words, what's secondary care and what's primary care. So one of the changes we've made based on those interviews is originally we had the secondary care first, and that has to be first because it's the most salient events. People are more likely to remember them, and then primary care second. But now we're going to change the guidance in the next iteration to say you can put primary care first, because if that's more important in your trial, collect that first, because that's what people remember. And the reason for that was in the Tiger trial, I found in one of the interviews, the parents were trying to fit in primary care in the secondary care questions because they weren't relevant to them, but they didn't really understand the difference. So they were putting primary care into secondary care. Yeah, so I'd really recommend doing Think Aloud interviews for resource use measures, because you would never think these things happen, but they do.
Yeah. So we find the same thing with quality of life stuff. The way that the general public understand these ideas that we all have a kind of a mutual agreement on what they mean. Public understanding can be so different that the Think Alouds are really valuable. I think it's a really really important step. Are there any other questions from attendees? I was really glad to see the external validation stuff you have proposed as well. I think that's really valuable. I think that there's this kind of tension between the recall period and the kind of the comprehensiveness of the data, and the further you go back in time, the less reliable it is. So trying to get that sweet spot is really really important. I also thought the societal perspective module that you're building is going to be really important as well. Like in Australia, we generally go for a health sector perspective, but that's mainly because of data availability as much as anything. So Emily Atkins asks, are there plans for an Australian adaptation? Which I think is the question we're all actually itching to get an answer for.
We'd love to do an Australian adaptation, but we can't get funding to do it within the UK. So if anybody wants to collaborate, yeah, we'd be very interested in trying to adapt it. And I think it would be really interesting actually to see how much adaptation is required, how different the systems are.
Yeah, so we've been running a trial which has a UK arm and an Australian arm at the moment, and it's actually quite different. Like there are, like the systems are really genuinely quite different in terms of having multiple major funders of healthcare, which you don't have in the UK in the same way. So that's
okay.
It would require a fair amount of work. We don't have any other questions, but I had one about unit costs. So obviously this is about collection of resource utilization. I wondered if there was the potential for extending it to auto-populate in terms of unit costs as well, like or suggestions for likely unit costs that people might use with source data. But that would be quite interesting, would certainly help trialists looking to use Modrum.
Yeah, we've definitely thought about it, that it'd be nice to have some sort of cost compendium to go alongside Modrum. I think the difficulty is that they're changing yearly or more frequently, so it'd take a lot of work unless we find a way to do it automatically on our behalf to sort of keep that updated. But I think maybe just telling people where to go, where we think they should go, rather than having a cost, would be a first step that we're interested in taking forward.
Yeah, I think that would be really valuable. If additional funding is available, that would be a direction that I think would be really valuable for trialists, because even economists don't always know exactly where to go for the range of resource utilization that's included in an instrument like this. So having that would be terrific. Last call for questions from the audience. Lisa, was there anything you wanted to ask? Lisa's co-chair of the special interest group.
No, and apologies, I'm in the airport and it's quite loud. My apologies that I can't. But I think that having a standardised questionnaire that can be validated in Australia, at the moment we sort of use a whole lot of different questionnaires, and I think having something that's had the amount of work that you've put into Modrum with the validations that you've done is really important, and being able to look at whether we can adapt that in the Australian setting, I think is something we should definitely look at as an ACTA HEAT group. What funding streams could we look at to do this with you?
Absolutely. Yeah, it's a great shared resource, and it's wonderful to see the uptake that you've had already in the UK, and I'm sure there's a lot more to come as well. Okay, well, if we have no additional questions, I'd like to call the session to a close, and just to thank you again, Joanna and Kirsty. I think that, as I said, the contribution you've made in UK health economics with Modrum is large and growing, and the potential for impact here as well is terrific. And I hope some members of the Australian community will reach out to you and initiate that work, because I think it helps us all to have that kind of standardized work underpinned by good validity studies and so forth. So I really think it's valuable and terrific work. So thank you so much, and thank you all for dialing in as well.
Thank you.
Thank you. Thanks for inviting us.
Thanks, everybody.